Hi, everyone. Thank you so much for joining us today. I'd like you to please welcome Dr. Mark Niciu, who is an assistant professor in the Department of Psychiatry at UIHC, and he's a member of the Iowa Neuroscience Institute. Dr. Niciu is a native New Yorker. He completed his bachelor's degree in biology and philosophy at Manhattan College and a combined MD PhD program at the University of Connecticut Health Center's Medical Scientist Training Program. He completed his residency at the Yale T32 Neuroscience Training Program and a clinical fellowship at the NIMH Experimental Therapeutics and Pathophysiology branch. And there he conducted innovative studies on the antidepressive properties of ketamine, which is what he'll be talking about today. He is the recipient of several research awards, including a NARSAD Young Investigator Award and a Pathway to Independence K99R00 Award from NIMH. Dr. Niciu transitioned to the University of Iowa in 2018, where he has continued his program of research, and he's played an instrumental role in establishing ketamine clinical services at UIHC. So welcome, Dr. Niciu, and I'll turn it over to you.
Oh, thanks so much, Amanda, and I really appreciate the opportunity to talk here. When I first arrived in Iowa in 2018 or 2019, I don't remember exactly now, but I did a talk on ketamine at the Iowa NAMI meeting in Des Moines, and a lot has changed since that time, including the FDA approval of esketamine for treatment-resistant depression. So hopefully this will be a pretty substantial update. If any of you heard that talk, going to be similar content, but again, significant advances with esketamine. So just disclosures. So I'm a site principal investigator for a bipolar depression study, not related to anything I'm going to talk about today. So this is a P2XR receptor antagonist in bipolar depression. And I'll actually do maybe a little bit of advertisement for the study at the very end, if we have time for that, but it's not related to esketamine or ketamine. So just a quick outline of what I'm going to talk about. So I'm going to talk about ketamine and esketamine, and we'll talk about the differences between the two, its antidepressant mechanisms of action, and some functional brain responses that have been shown to correlate with antidepressant activity. I'm going to talk about the clinical studies after that. So I'm going to move from more mechanism to clinical efficacy, talking about racemic ketamine first, mostly IV infusions for treatment-resistant depression, intranasal esketamine, or Spravato, as the trade name has been called, for treatment-resistant depression. It's also subsequently been approved for major depressive disorder with acute suicidal ideation and behavior. And then what are some of the things as clinicians and patients that we need to think about who are good candidates for ketamine and esketamine? What do the sessions look like? Because this is not like a typical psychiatric medication where you take it home, even though some people are doing take-home oral ketamine and nasal ketamine. It's not something that I do currently clinically. And Spravato sessions have to be in a supervised setting, so it's not a take-home device. But before I talk about that, I know we have a lot of very savvy people on the phone call, but I'm just going to give a brief overview for major depressive disorder and bipolar disorder, just to set the stage and talk about the current armamentarium, at least of antidepressant medications. So as many of you know, so major depressive disorder is defined as at least 2 weeks of the following. So the two mandatory, where at least one of these two symptoms are necessary for the diagnosis: depressed mood and either increased or decreased or loss of interest. So anhedonia, or one of the two sine qua nons of the diagnosis. But there's, many of you might have heard, an acronym that we use frequently called SIGI-CAPS. It leaves out the D in depressed mood. So a lot of times I'll teach the residents D-SIGI-CAPS, and something I still use clinically very frequently when I'm interviewing patients for clinical services here. But these are the symptoms for depression. You need at least 5 of these 9 for 2 weeks. So depressed mood, changes in sleep, anhedonia, feelings of guilt, worthlessness, decreased energy, focus, concentration impairments, changes in your appetite, and suicidal thinking. And typically, this has to be not explained by an alternative diagnosis, so a medical condition like hypothyroidism, or due to substance use, for example, alcohol use disorder, or cocaine withdrawal, methamphetamine withdrawal. So And then it has to cause functional impairment. So it has to have not only you have these symptoms, but an outside observer would say that this is impairing your life in some way. And with bipolar disorder, there's two kind of flavors that we often think about, even though there used to be a bipolar NOS category. Now there's bipolar 1 and bipolar 2. So bipolar 1 being the more severe manifestation of the illness. And they're defined by having either manic or hypomanic episodes. So at least 1 week in bipolar disorder type 1 and at least 4 days in bipolar disorder type 2 of some of the following symptoms. And there's another acronym that we use called DIGFAST, and you see those symptoms there, but that excludes, similar to depression, the elevated expansive or irritable mood, which is necessary for the diagnosis. But some of these other things during a manic or hypomanic episode, distractibility, increased impulsivity, grandiosity, flight of ideas, usually increased activity, a decreased need for sleep, which I think a lot of clinicians consider to be one of the harbingers of a manic or hypomanic episode, and then increased talkativeness. And has to be, again, not better explained by an alternative etiology, so hyperthyroidism in this instance, or by substance use or withdrawal. Good example of a medical treatment that can cause symptoms resembling mania or hypomania is corticosteroid administration, so something like prednisone. And again, it has to cause functional impairment. So there are many treatment options pharmacologically for major depressive disorder. I'm going to really talk again on the depressive pole at this point, even though just to kind of mention that, even though we talked about bipolar mania and hypomania, ketamine is only indicated for the depressive aspects of these disorders. So, but real world clinical trials for both major depressive disorder and for bipolar depression have revealed a critical need for novel treatment options. So some of these studies might be familiar to people in attendance. In the late 90s or early 2000s, there were several studies that came out that were kind of real world all-comer type studies where people were just trying to assess the efficacy of our standard treatments. So the first treatment is called STAR-D. There's about 3,000 participants where people could be, first you were started on citalopram or Celexa. It's pretty standard SSRI. And then depending upon how you did with that, followed through various steps of an algorithm and getting all the way down to ECT. So there were generally low remission rates in an all-comer population with citalopram only. The way I kind of think of this study was about 1/3 of patients had remission, 1/3 had a response, so at least a 50% improvement, and 1/3 had very little, if any, response at all. And as you can guess, the more treatment trials you accumulated in the study, the worse the outcome was, getting all the way down to ECT, where, if I remember correctly, only about 20% of the patients who received ECT responded to ECT in the study. Another study is kind of similar in design to this one, an all-comer study looking at combining medications, which is something we often do for other disorders like diabetes or hypertension. So medications with complementary but unique mechanisms like escitalopram and SSRI and bupropion, which is a dopamine reuptake inhibitor. Venlafaxine and mirtazapine are two medications that are often co-prescribed together. And this was compared to just escitalopram, so just starting a standard SSRI plus placebo, and they actually saw no difference whether you started 2 antidepressants at once or just one. So unlike other disorders where that can make a huge difference, as in diabetes and lowering hemoglobin A1C. Similar studies have been done in bipolar disorder. There was an analogous study to STAR-D called STEP-BD, where patients, again, followed a pretty regimented algorithm going through various steps based on their illness. Something in the chat. Okay. So people were oftentimes continued on mood stabilizers, or they could have been given antidepressants in this study. So standard SSRIs, other classes of antidepressants, and it really made no difference on their depression, whether they received an antidepressant or a placebo, if they had a primary diagnosis of bipolar disorder. Didn't improve outcome. And some people would argue it actually increases the risk for antidepressant-induced mania. And then another study was looking at lithium treatment in an all-comer population where people were on moderate dose lithium or standard outpatient treatment versus placebo and standard outpatient treatment. And this was a long study. This was up to a year. And in this study, when they looked at functional outcomes, ability to work, sustain relationships, familial outcomes, like how motivated you are to interact with your children or family, etc. They saw no difference in several functional outcomes. So pretty sobering. And, even though I recommend and use lithium a lot, some studies have suggested that the functional effects are not as dramatic as we would hope or like. So all this to say that there is a need for treatments that have novel mechanisms in both unipolar and bipolar depression. And one of the potential candidates that has now been studied since 2000s has been ketamine. But before we talk about the clinical efficacy, I'll talk about how ketamine works and what are some of the hypothesized mechanisms leading to its antidepressant response, which is oftentimes very rapid in comparison to other treatments, including medications. So ketamine is a synthetic derivative of phencyclidine, or PCP, which is a dissociative anesthetic, can have intense psychotomimetic or hallucinogenic properties in some people. And ketamine's first approval and only approval in the United States has been as a dissociative anesthetic. It's not approved, FDA approved. I'm talking about the parent compound. Ketamine has not been approved for major depressive disorder, bipolar depression. So just be mindful, everything I'm talking about is research and off-label treatment here. So ketamine, as unlike the other medications that tend to work on monoamines, so serotonin, dopamine, norepinephrine, ketamine's primary mechanism of action is through glutamate, in particular as an antagonist at this NMDA, the main glutamate receptor in the brain. But it's a very complex interplay of receptor antagonism. And there's actually a new study that came out and said NMDA receptor agonism might have a role in ketamine's antidepressant response, which only murkies the waters. But the way I kind of talk to people about it, just based on the current state of the knowledge, is ketamine is more of a glutamate modulator. It kind of restores an excitatory inhibitory balance in a very rapid way. And the S enantiomer of ketamine, or S-ketamine, similar to citalopram and S-citalopram, which I just showed, has greater affinity for the NMDA receptor, which is part of the reason why Janssen or Johnson & Johnson went after that derivative. If the NMDA receptor has a major role in the antidepressant response, if it has greater affinity, theoretically, you'd anticipate it to have greater antidepressant response. But ketamine, like a lot of other psychiatric medications that are highly effective, and I oftentimes will talk about ketamine being kind of the clozapine of depression. It has a lot of off-target effects. So it has dopaminergic effects, it has anticholinergic effects. More popularly lately, it has a lot of advertised opiatergic effects. So it's not clearly effects just on glutamate and the NMDA receptor that are responsible for its antidepressant mechanisms. And I'm not going to really talk about that much, but just be mindful that it's a very sloppy drug. And unfortunately, in overdose are people who abuse ketamine, because it is a scheduled compound. It's a Schedule 3 compound. It can have a lot of untoward effects in overdose. So it can cause dissociation, psychosis, can cause hypertension, tachycardia due to its dopaminergic effects. And in people who abuse ketamine, and something we consider clinically when we see people, if they have baseline urinary dysfunction, it's something we need to pay close attention to. But in people who use ketamine and abuse it, they can have a permanent urinary tract dysfunction, a urinary cystitis that can be very problematic for the rest of their life. But thankfully, it's rarely lethal in isolation. And the reason why it's used frequently in anesthesia, because it causes very minimal respiratory depression, unlike other substances such as opiates. And this is a review that I wrote in residency, fellowship. Now it's a little bit dated, but I think it kind of highlights the important aspects of ketamine's antidepressant response. So as I mentioned, and I'll kind of use the pointer on screen here, this is ketamine in the synaptic cleft. So this would be a presynaptic neuron, a postsynaptic neuron here. And ketamine blocks and binds and blocks the NMDA receptor. But when it does that, there's some upstream targets that actually leads to increased glutamate being released. And glutamate preferentially acts on another type of glutamate receptor called the AMPA receptor. And these are really fast-acting glutamate receptors. It causes a rapid influx of calcium and downstream depolarization of postsynaptic neurons. but there's a very intricate and complex interplay of signal transduction or second messenger pathways, leading ultimately to increase in BDNF, so brain-derived neurotrophic factor, its local translation, so the production of the protein and its eventual secretion. And the kind of way I talk to patients about this, and oftentimes we'll even just draw something that looks similar to this. So when patients are depressed, or if you stress animals, they can have this synaptic destabilization where a mature spine kind of becomes more flimsy appearing. And as people recover from depression or things like learning and memory, there's synaptogenesis where these more destabilized spines become more mature or mushroom shaped. And this mushroom shaped spine is, again, one of the structural correlates of learning and memory, but is also a strong structural correlate of antidepressant efficacy in certain areas of the brain, like the prefrontal cortex and the hippocampus. So just kind of 30,000 foot description of the antidepressant response here. And we can talk more about this at the end if you like, but and this is a review that a grad student in my lab and I wrote earlier this year, looking at, or last year now, looking at functional connectivity patterns. So not only does ketamine affect the synapse, but it affects overall brain responsivity, as you would guess. And there are many areas of the brain that are implicated in ketamine's antidepressant response, but some of the ones that have come up repeatedly across numerous studies are the anterior cingulate cortex, and prefrontal cortex. And these areas here, where if there's a straight line, for example, the insula to the cingulate cortex, ketamine increases connectivity. If there's a dotted line, for example, the anterior cingulate cortex to the amygdala, it's actually decreasing. So the amygdala pathway is oftentimes associated with fear and anxiety response. So you want to kind of quiet that part of the brain down and strengthen the prefrontal cortex. And we see that here where the PFC is kind of strengthened if it has this halo around it. That's an area of the brain that's been shown in another form of neuroimaging called global brain connectivity. So this is an area of the brain that is strengthened by ketamine administration. So, so diverse effects on the brain. But I'm kind of going to move into now some clinical studies. So to kind of discuss the evidence and where we are currently with first racemic ketamine infusion for treatment-resistant depression, and then I'll talk about the intranasal studies as well. So. Okay, so the initial ketamine depression study came out in 2000. So people oftentimes they'll be like, "Oh, this seems very new," and kind of dating it now. But I've been working in this field now for 10 plus years. But the first study was conducted in the late 90s and reported in the 2000s. So almost 25 years now worth of data on ketamine and depression. So this was a sample that was a study that was done at Yale, where they had ketamine at a sub-anesthetic dose. So the dose I'm going to show throughout is 0.5 milligram per kilogram IV over 40 minutes. So patients received a 40-minute infusion at this low dose, and then they were followed in this study for up to 3 days. And as you can see, there's a pretty rapid separation from a placebo infusion. As quickly as the same day, so about 4 hours after they started the infusion, and the antidepressant response in this cohort persisted for at least 3 days. They didn't follow the patients longer here, but we'll see some studies that have followed the patients for longer periods of time. And one of the critiques that I'm sure that they got when they designed the study is that, are we really just kind of getting people high, or they feel different? And that's really explaining the antidepressant response. And there's a temporal dissociation of those symptoms. So as you can see here, this is two scales looking at first intoxication. So the visual analog scale, feeling high or intoxicated. Certainly ketamine causes those type of symptoms, but it resolved within 2 hours after administration, while the antidepressant response started after that. Similar to with the BPRS positive symptom scale. So these are psychotomimetic-like experiences, psychosis, dissociation. Again, a rapid increase in those symptoms, but they resolved quickly and temporally dissociated from the antidepressant response. Another major complaint that the study received and some other studies is the adequacy of the placebo. And if you've seen any depression clinical trials, one of the major problems in depression studies is not so much that the medications don't improve depression, but they fail to separate from placebo. And as you can see here, There's very little placebo response, which is atypical for depression studies, and that kind of magnify the antidepressant response of ketamine. And the argument would be that everybody knows they're getting ketamine or they're getting placebo based on this. So kind of see that there. So okay, so moving on. This was again early to mid 2000s. Another study was performed by the NIH, and this is the group that I subsequently did my fellowship with Carlos Serrati. And this was looking at treatment-resistant depression. In particular, in this study was major depressive disorder. They didn't have any bipolar subjects, unlike the last study. And they had a slightly different design here where they had crossover. So everybody got either placebo or ketamine with a washout period in between. Same dose and same duration of the infusion. But you'll see, again, very little placebo response with the saline infusion, and a rapid, and in this case, a maximal response at 24 hours, and a subsequent slow return to baseline after about a week. So they kind of looked more at the time course in the study. They did the same thing with bipolar disorder, and the concern here was that ketamine, similar to what's proposed with some typical antidepressants, it can cause an affective switch or induction of mania or hypomania. So this study had patients had to be maintained on therapeutic doses of lithium or Depakote for the duration of the study, but similar design. They were randomized, crossed over, and again, very little placebo response, but you see a dramatic antidepressant response of ketamine as early in this study as 40 minutes, so right at the end of the infusion, and it lasted approximately a week in the study, again, still separating from placebo at day 3. So both these studies were single infusions, used a saline placebo. So as I've already alluded to, a lot of critique was that really we're exaggerating the response, and if people got something that was psychoactive, would we still see an antidepressant response with ketamine? So in the late 2000s, several studies were designed using midazolam, which is a short-acting benzodiazepine, as a psychoactive control. It'll capture some of the symptoms of ketamine, so it'll cause sedation, will cause very rapid change in sensorium, but it typically doesn't cause the psychotic-like experiences. So it's a little bit different in that regard, but certainly better than saline. So this was one of the largest academic sponsored studies, or where they had 73 patients who were unmedicated. Again, they had treatment-resistant major depressive disorder. And in this study, they were randomized 2-to-1. So for every 2 patients who received ketamine, there was 1 patient who received midazolam. And you can see that reflected in the overall numbers here. So more patients received ketamine. And contrast to the prior studies, you see a significant placebo response here, as you'd expect in a lot of depression studies. Yet ketamine still separated at day 1, day 2, day 3, all the way out to day 7, even though these lines are converging more now as you approach day 7. And when they looked at response rates between the 2 groups, ketamine had a greater response rate as defined by a 50% improvement from your baseline depression score. So if you had for example, a 30 on the MADRS at the start of the study, you'd have to score at least a 15 at these time points to be considered a responder. And again, greater response rates at day 1, 2, 3, all the way out to day 7. So if you responded well to ketamine, you kind of sustain that response for the majority of the study. So kind of quelling some of the critics that were, it's really just the psychoactive properties and not anything specific to ketamine that's driving the antidepressant efficacy. And so then a lot of other studies, and I'm kind of presenting more of a timeline approach here to ketamine. So all these studies really used 0.5 milligrams per kilogram. It was a sub-anesthetic dose. Some of that was based on some preclinical or rodent-based studies, but nobody had tried other doses. For example, 0.1, 1 milligram. Once you get above about 2 milligrams, you're talking more of the anesthetic dose range, so 2 milligrams per kilogram IV. So a study was designed, Multisite, in the late, I think 2000s, 2010-ish, where they had, again, a large cohort of patients use midazolam as a psychoactive control, and then randomize people to ketamine at various doses. And I'll show that in the right panel in a second. But whether you got midazolam or ketamine, there's a clear difference in your antidepressant response. They also used a little bit different depression rating scale score here. So the things that might respond more rapidly, for example, changes in mood, suicidal thinking, you'd expect those to respond more quickly, obviously, than changes in sleep. So they have an abbreviated version of the Hamilton Depression Rating Scale score here and showed a clear separation as early as day 1. But when they looked at the individual doses, it was unfortunately underpowered to detect differences between the doses, but the ones that separated from placebo were, in this study, the 0.5 milligram per kilogram, which is here, and the 1.0 milligram per kilogram. This dose here looks numerically pretty impressive, but it didn't separate from placebo. So thankfully, the field kind of stumbled upon the correct dose, 0.5 milligram per kilogram, but it looks like 1 milligram per kilogram would also be reasonably effective. And I know a lot of practitioners in the community will oftentimes start at 0.5 and then titrate the dose based on the patient's response. So if you're tolerating it well, you can increase the dose, which is also something we do with esketamine. And I've showed several studies now where the antidepressant response lasts for about a week, but then people start returning. There's no medication in psychiatry and pretty much any field where you see a single administration and expect a permanent change. Let's see, is there something in the chat? Okay. Is there any risk of ketamine inducing mania in bipolar patients similar to what can happen with SSRIs? So that's a great question. So there's mixed literature out there. So in the sample from the NIMH, this was a Roddy sample when I was there. I had a brief report in biological psychiatry that we didn't see any evidence of effective switching beyond placebo. But these patients were maintained on either lithium or Depakote at therapeutic levels. So I think it's still an outstanding question. There are certainly case reports of ketamine causing hypomanic to manic-like symptoms in hospitalized patients, for example, or people who are receiving higher doses, but it's not as well described, I think, as for other antidepressants. So, good question. Thank you. Okay, so this is a repeated ketamine infusion study. So as you could guess, you want to kind of, if you're getting antidepressant response with one infusion, let's try it again and see how it does. And the initial study was designed kind of with ECT in mind, doing Monday, Wednesday, Friday administration, and over 2 weeks. So kind of an index series, which what you would see with ECT. So, and this was a study that came out from Mount Sinai, where they had 24 patients with treatment-resistant depression. They were open labelly administered 0.5 milligram per kilogram IV ketamine 3 times per week over 2 weeks. And then they were followed prospectively for 90 days, which is really powerful. So you can see one of the things, I think, take homes here, and there's several other studies that have validated this, is that if somebody's going to respond, they usually know pretty quickly. So you almost see a clear separation between these two groups. So the phase 1 responders and non-responders as soon as after their first infusion. But there are some people who oftentimes require a few infusions to see a response. So, but you see this separation where subsequent infusions really just maintain the response. It didn't really add much maximal benefit. It was almost a basement effect here. You really couldn't get much better than what you're seeing right here after 6 infusions. Whereas the more administration you gave to the non-responders, it didn't really make much of a difference. It's not like there was some intermediary phenotype that they reached. So it's one of the benefits with ketamine. If you're going to respond, you usually know pretty quickly. So within 3 to 6 infusions, you have a sense. And then when these patients, the responders, were followed for 90 days, and these people could get treatment in the community, psychotherapy, medications, etc. There was relapse, as you would guess, when they stopped ketamine, but there wasn't 100% relapse. Some of these patients still sustain their antidepressant response. So for some people, this might be a time-limited treatment. For a lot of patients, it's not. They might need a booster course or more frequent administration, maybe once every few weeks or something like that. And people do that in the community as well. So, but there are some people who do really well, at least for 90 days after receiving ketamine. And this was a study that came out from Janssen, and I'm going to kind of use this to transition into some of the esketamine studies, because when they were designing their esketamine studies, they wanted to know, what would be the optimal dose? Would it be twice weekly dosing or 3 times per week dosing? They didn't have once per week here, which I think would have been pretty interesting to see. But overall, they didn't see any difference whether you received an IV ketamine infusion once a week twice a week versus 3 times per week. At the end of 15 days, the overall outcomes were not different, just looking at mean changes in the baseline MADRS score compared to an inert placebo. So subsequently, their clinical trials, they used intranasal esketamine twice weekly, which is what it's been FDA approved for now. Okay, so I'm going to talk about that. Again, try to leave a lot of time for discussion and questions at the end. So there have been several studies, and these are the difference between industry-sponsored studies and academic-sponsored studies. Industry-sponsored studies for FDA approval require hundreds of patients. So you'll see some of the numbers being much larger than what you would see in the academics studies, where if we get 70 patients, that's considered great recruitment. So that's minimal for an industry sponsored study. So these studies are a little bit different in design. So a lot of times, or these patients were either maintained on an antidepressant that they were already on, so an SSRI, SNRI. But if a lot of studies had people switch their antidepressants too. So for example, if you came in on an SSRI, they would switch to venlafaxine and SNRI or another antidepressant, and then demonstrate a prospective failed trial of that antidepressant. So a little bit more stringent than what you see with the IV ketamine studies. And these patients were randomized to receive either an antidepressant medication plus placebo, or esketamine nasal spray plus that same oral antidepressant for a period of 4 weeks. And you see a significant improvement in antidepressant response, again, based on the MADRS here. It's separated in this study, I think, as early as day 8, and was maintained throughout the duration of the study. Actually, I think this was the only significant point here. I'm sorry about that. So day 28, so that was the endpoint here. But again, 100 plus patients in each arm here, so 200 patients per group. They looked at some of the predictors of response. So this is a lot of times questions that I'll get is like, how do we have a sense whether a patient would respond well to ketamine, ECT, TMS, and still a very open area of investigation. But some of the things that they saw in their study that predicted response were greater antidepressant resistance. So if you had more than 3 treatments, you were more likely to respond to esketamine, and if you had greater disability. So, in contrast to some of the other things I showed with lithium, where it didn't seem to have much effect on these things. So if you had greater disability, you were more likely to have an antidepressant response with ketamine. I don't think they show that ketamine leads to a significant improvement in the disability scale rating, but greater baseline disability and greater resistance. And you can imagine that those things are correlated, led to a greater antidepressant response with esketamine. And so this is another study that they where they used again twice per weekly dosing of esketamine. Oftentimes with esketamine, we can escalate the dose to 84 milligrams if people are tolerating it well, but you can always go back down to the starting dose of 56 milligrams if you're not. And then compared to placebo, so a nasal saline like ocean spray 2 times per week for 4 weeks. And in this study, they had 68 patients that were optimized to standard of care medicated TRD. And similar to what I just showed, this is another trial with the same design, but an independent cohort where they had esketamine plus antidepressant, placebo plus antidepressant, and showed a significant improvement here at day 2, as well as day 1. So the same day as well as the next day. And when they followed these patients again for 28 days, a separation of placebo from esketamine at various time points in this study, they showed it at day 1, 2, 4, and 11. So you see kind of, differences in overall antidepressant efficacy. But and then the other thing that they looked at, and I think one of the real powers of ketamine and esketamine, is its effects on suicidal thinking. So this is kind of a complicated figure here, but I think you can look at this pretty quickly as see you want to move from less red and blue to more green and orange. So you'll see from the legend below, this is the MADRS score from 0 to 6, where 6, 5, 4 indicates a high level of suicidal thinking. And a lot of these patients came in with significant suicidal thinking, the majority of them. So where they were considering at least being better off dead or had explicit plans for suicide. And you see a really kind of dramatic shift going from those groups all the way down to at the end of treatment, where there were many more patients who were saying that they enjoy life, they take it as it comes. They saw a lot of that with placebo as well. Just be mindful of that. But this was a statistically significant difference in the kind of the green and the orange. This cohort was greater than this cohort here. So, and that subsequently led to the anti-suicidal approval for esketamine nasal spray, which is a first in class. There's no other depression treatment that is specifically approved for suicidal thinking. And so a question I oftentimes get asked is which is more effective, IV ketamine or intranasal esketamine? And the long and short is these have not been studied in the same trial head to head. So this is all based on meta-analytic data, so comparing and statistically analyzing data across different trials. But when they've looked at this, and you can see here, I know this font's pretty small here, but one of the things I want to draw your attention to, these are all really academic studies with IV ketamine. They had a total of 780 patients over 20 years. And you can see some of these esketamine patients, this is again, Johnson & Johnson, they had greater number of patients in a much shorter period of time, a decade, if that. So the majority of the patients in this meta-analysis received esketamine. In this study here, they showed that the experimental rate, so meaning does it favor ketamine versus placebo, it certainly favored combining all the data together, IV ketamine as well as intranasal esketamine. Similar thing when you look at the remission rate, combining all the data together, IV ketamine as well as intranasal esketamine have significant effects on the antidepressant remission rate. And then overall change in depression rating scale score. So on this side, this would be considered an antidepressant response. So looking at the combined data here, so overall improvement. But kind of where the rubber hits the road is in this table here, where they looked at the results across the two different designs, and they show that ketamine, IV ketamine, has a greater effect on antidepressant response and remission, which is as defined here in these relative risk scores here. So it had a greater antidepressant response, but even maybe more importantly, it had fewer side effects. So the adverse effects here clearly favored IV ketamine over intranasal esketamine. And we can talk about why that might be, but typically what I tell patients is that, we might expect IV ketamine to be, we might expect IV ketamine to be more efficacious, but considering the potential out-of-pocket expenses, IV ketamine is usually not covered by insurance, while as intranasal esketamine is. To me, those are the more important considerations. That would make sense to try the IV ketamine after potentially you receive intranasal, but not before for a lot of people. So, but where would we put this in the kind of treatment algorithm? So, this is my opinion. There's no kind of consensus statement from the field about this, but after kind of several considerations, and these are things I consider when I see people from the interventional psychiatry service, if they're thinking about ketamine, I would put intranasal esketamine kind of after antidepressant combination, augmentation, including evidence-based psychotherapies, but before ECT. So kind of putting it on the same footing with transcranial magnetic stimulation. Oftentimes when we talk about these things as a team, is somebody a good candidate for TMS or ketamine is kind of how we'll oftentimes approach our evals. But if it's affordable and preferred, it might make sense to try IV ketamine in a lot of instances. Again, slightly more efficacious, certainly fewer side effects, but certainly before ECT. But and then I think it's generally unlikely that patients will respond to IV ketamine after a failed index course of intranasal esketamine, even though I've heard from some people who do this that's not always the case. So kind of the jury's still out on that, but my sense is that it's unlikely that people will respond, but it's case by case in a lot of ways. So, okay. So that's a lot of the data. Now I'm really just going to talk about the sessions themselves and what we think about when we evaluate patients, and hopefully I've peppered some of this throughout the talk already. So, so some psychiatric evaluation considerations. So again, the primary indication here is treatment-resistant major depressive disorder. These esketamine has been, or IV ketamine has been studied in bipolar depression, as I've shown. It has not been studied in IV or intranasal esketamine has not been studied in bipolar depression. Unlikely to be studied. Janssen's not currently pursuing this. There might be some indication for off-label treatment, but sometimes insurances might not cover that because it's not the FDA-approved indication. So, so the primary indication is treatment refractory depression, is defined usually by greater than or equal to 2 failed antidepressants in a current major depressive episode. Things to consider with bipolar disorder. So if somebody is a rapid cycler, I would be much less likely to prescribe ketamine, based on the question that we've already had. I'm get very worried about effective switching. And I would say that they have to be on a therapeutic dose of an anti-manic mood stabilizer like lithium or Depakote, again, to reduce that risk of effective switching. If there are certain definitive exclusions, if somebody has a psychotic spectrum disorder like schizophrenia or schizoaffective disorder, ketamine could worsen the psychosis. So we would not want to give ketamine to those patients, unfortunately. And then substance use disorders, especially active substance use disorders, as I mentioned, both of these are Schedule III compounds. If somebody's actively abusing drugs or alcohol, I don't think they'd be a good candidate for ketamine. I just don't want to add another potential substance of abuse to the mix here. And if somebody has a lifetime substance use disorder, it's concerning, but it's not a definitive exclusion. So, and I think as I've gotten more comfortable with ketamine, I've kind of softened to this over the years too, that if somebody has a history, for example, of lifetime alcohol use disorder, I'm not as worried about ketamine triggering their desire to drink, for example, as I was maybe 10 years ago. And the other kind of flip side, and a lot of times it's something we don't consider as much, but we get a lot of people who are more substance naive. So they haven't really drank or they haven't used cannabis. And ketamine is kind of like a lot of these patients more like jumping off the deep end. You want to learn you need to learn how to swim before you can find maybe these experiences more positive. So in my experience, a lot of these patients who have been substance naive, they find the experience of receiving ketamine to be unpleasant, scary. There's a K-hole phenomenon that can occur in a lot of people. And I think if you're not kind of primed to that, you might not be a good fit for you, for example. I don't think there's any efficacy change, but again, it's kind of going from 0 to 60 pretty quickly. Dissociative disorders, including PTSD, people have described to me as finding ketamine unpleasant or triggering in these instances. Even though there are many studies showing that ketamine is effective for PTSD, I think it really needs to be carefully prepped about what they might experience during ketamine administration itself. And then finally, pregnancy and lactation. So ketamine and esketamine are both category N. Females of reproductive potential need to have negative pregnancy tests at the start and potentially prior to each administration. Okay, so what does it look like pre-infusion? It's pretty similar to any sort of medical procedure where you have to be nothing by mouth or NPO, except for meds or small sips of water for at least 4 to 5 hours. One of the risks is that ketamine can cause nausea and vomiting. I say no alcohol or other substances for at least 8 hours prior. No scheduled or PRN benzodiazepines or opiates or narcotics for at least 8 hours. There's some pretty strong evidence that the antidepressant efficacy of ketamine might be reduced by co-occurring benzodiazepine administration. Again, and getting back to that excitatory inhibitory balance that we're trying to restore. And we use rating scales frequently. We use the PHQ-9, we use the MADRS, and I think without rating scales, it's really hard sometimes to gauge response. So it's something I'd recommend in clinical practice as well. If you're thinking of or doing, for example, intranasal esketamine, is the importance of having sequential ratings throughout a treatment course. So the infusions themselves, the nurses obtain IV access, they prime the pump, they essentially run the infusion. we only use 0.5 milligrams per kilogram. I'm not compelled that there's any evidence, strong evidence for dose adjustments, even though a lot of people will do that in the community. And then we monitor vital signs throughout. So respiratory rate, sedation, dissociation, side effects. We really sit with the patient, provide reassurance with them. It's rare that we ever need to administer kind of a rescue medication, but we have those on hand if needed. And then oftentimes we'll co-administer or re-administer the rating scales at 1 hour post-infusion after people have recovered from the experience. So some of the side effects with ketamine, and these are similar for esketamine. There's really no dramatic difference between the two, other than they just can be more pronounced with esketamine. So some of the sympathomimetic side effects, so increases in blood pressure and heart rate, the psychotomimetic or dissociative side effects, and these things are, more kind of on the illusion scale, where people will feel like colors are more vibrant or that sounds are louder than they ordinarily are. It's very rare at the doses we're using to ever see frank hallucinations, paranoia, or delusional thinking. And then again, these depersonalization or derealization experiences, feeling like you're out of body or disconnected with reality in some way, those are very common with ketamine. And then oftentimes during infusion, people will often kind of feel negative. And again, this might be related to your experiences with substances previously, but this intra-infusion dysphoria is very common, where people feel anxious or just kind of like almost analogous to some of the negative symptoms of schizophrenia, oftentimes kind of shut down in some ways. Neurologic side effects, sedation is very common. Dysgeusia or metallic taste in the mouth is common. Perioral numbness or tingling, this is kind of an anesthetic response. And then dizziness, nausea, vomiting, vertigo, as I all mentioned. It's very rare to see any of these side effects, but like with ECT and other systemic interventions, is something that could be the case. But again, knock on wood, we've never had any of these things happen in our clinical treatment. And then we talked about some of the long-term side effects already. So urinary side effects, hepatobiliary, so ketamine is metabolized by the liver. We need to check liver function tests. And then there's a theoretical risk of substance use. I think probably the more concern would be tolerance. So building up a tolerance to the antidepressant response, thankfully hasn't been seen, but again, it's a theoretical concern. And we talked about this, most of the side effects respond well to reassurance or validation, rarely necessitating the stopping the infusion. You want to maybe consider pausing the infusion, not necessarily lowering the rate, to kind of let people get their bearings again. And then we do have adjunctive medications for various symptoms if needed. And then after the infusion, we give people something to eat or drink. Oftentimes they've been NPO for hours. We remove the IV catheters, we continue vital sign monitoring, and just generally, a lot of times we get questions about the rest of the day or what they should do during treatment. So we say no driving or operating heavy machinery, and we recommend no non-prescribed drugs or alcohol for at least the remainder of the day. But people can go back to work the next day. They can, essentially resume their lives. Most people just want to go home and kind of chill out. So we're not really struggling with people getting out in the field and operating heavy machinery after they've received ketamine. So, and I'll talk a bit about Spravato. So again, 2 FDA-approved indications to date: the adjunctive treatment of treatment-resistant major depressive disorder, always a mouthful to say, and then MDD with acute suicidal ideation or behavior. What's different about intranasal esketamine is that there's this risk evaluation and mitigation strategy. Again, kind of bring clozapine back in. Clozapine has a REMS as well, where the healthcare site, for example, the University of Iowa, the University of Iowa's pharmacy, and the patient all need to be registered and followed during their treatment course. So the devices are provided to the patient. It has to be occurring in a medical setting. It has to be supervised by a healthcare professional. At the university here, we have a nurse who supervises the administration and monitoring. And these are all things that are FDA mandated. So we have to monitor these symptoms, side effects throughout treatment. So blood pressure, sedation, and dissociation at those 3 time points. People have to be in-house for at least 2 hours. And then again, no hazardous activities. And if somebody is pregnant or lactating, they're not a candidate for intranasal esketamine. And there are 2 phases. So we start at 56 milligrams, that's the starting dose, and then 2 times per week for 4 weeks. And then weeks 5 through 8 and beyond, we can decrease the frequency. And we have several patients who are in the maintenance phase. Usually maintenance is once every few weeks to every 2 weeks to 3 weeks. And have had people maintain their antidepressant response for years. Might have to increase the dose of the maintenance periodically, depending upon life stressors and the like. But we've had one patient who's been receiving it for numerous years, has done exceptionally well. This is what the device looks like. I'm getting towards the end here. So it looks like a pretty typical like Flonase device. There's, they kind of make it foolproof for the clinicians and the patients. So if a spray is delivered, the green dot goes away and the device is empty. You have to kind of sit in a reclining chair at 45 degrees, coordinate your breathing with the administration of the device, as shown here. And then if somebody is receiving 56 milligrams, we space them out 2 devices every 5 minutes, 84, 2 to 3 devices over 5 minutes. So a total of 10 and 15 minutes respectively. And these are some of the forms that we need to fill out. So we have the REMS forms, so for patients that are enrolling, and then every time somebody gets a session, so you can imagine it creates kind of a paperwork burden for us, but we have to complete this form. You can do it online, so it gets to be pretty easy, but these are some of the things we need to monitor, and the FDA is ensuring that we're doing these things. So again, what dose they're getting, the vital signs, sedation, dissociation. So pretty quick, but if you have a lot of patients, it takes some time. So. All right, so conclusions. So ketamine and esketamine is a first-in-class glutamate-based antidepressant with rapid and robust antidepressant efficacy in TRD. Sub-anesthetic dose ketamine infusions are safe and effective for TRD, but are typically not covered by insurance. So it's an out-of-pocket expense for patients, and they can be, University of Iowa, we have charged $500 per infusion, but I know some places are charging much more than that. Intranasal esketamine or Spravato, there's 2 FDA approvals for this. So adjunctive treatment in TRD, which was in 2019, and MDD with acute suicidal ideation behavior was in 2020. And although effective, the magnitude may not be as great and sometimes can have greater side effects and other challenges relative to the racemic ketamine infusions. Like there's no REMS for racemic ketamine, so it's less of a burden for practitioners than it is with intranasal esketamine. So, all right. And then finally, I'm just going to give very quick advertisement. So my group has a ketamine alcohol study where we administer an open label ketamine infusion as well as alcohol infusions. And one of the things my group is working on is predictors of ketamine's antidepressant response. And we've shown that people with a family history of an alcohol use disorder tend to have a better and more sustained antidepressant response to ketamine. So we're trying to unpack why that is and using alcohol challenge as a way to do that. For anybody who's in the interventional psychiatry service, they can enroll in biomarker studies. And if you look in the bottom there, we're looking at various measures of potential antidepressant efficacy, neuroimaging, electroencephalography, epigenetics, autonomic testing. So this is not specific to ketamine. This is anything that we offer, which is ECT, TMS, and ketamine, but we have this study as well that I'm the lead PI on. And then finally, the study that it's my disclosure, it hasn't started yet, but at the university, but this is a study of a novel anti-inflammatory compound in the treatment of bipolar depression. In order to enroll in the study, you'd have to be, or you cannot be unfortunately on antidepressants, so SSRIs, SNRIs, or an antipsychotic, which I think is going to be unfortunately limiting for a lot of people. But this is a study that if you're not responding well with bipolar disorder, in particular bipolar depression, and something again novel mechanism, nothing out there that's similar to this compound, looking at reducing brain inflammation in bipolar disorder. And these are my contacts. So my email and office number are there. I have a clinical research assistant, Nikki Schlegel. You can reach out to her if you so desire, her email and office number, my lab website, and also please feel free to follow the lab on Twitter. We don't have a Mastodon page yet, but Twitter seemed to calm down in the past month or so. So, all right, and thanks everybody for your attention. And any additional questions, feel free to either in the chat or just got a question here from Natasha. What, if anything, should a caregiver of someone who's receiving ketamine be aware of or watching as treatment begins? That's a really great question. So I think some of the things that would be most concerned about on the day of treatment would just be more like kind of how they're feeling. There's some evidence that not everybody who does well with ketamine might even have an increase in their suicidal thinking, for example, even though it is FDA approved. There have been some studies that show a very small segment of patients can actually have a worsening of suicidal thinking after they've received ketamine. I don't think there are any like medical risks really that we make sure people's vital signs are normal. Another thing I've seen when patients go home and the first night of treatment, oftentimes they can have very vivid dreams, and so I think making patients aware of that this might be more of a unusual night of sleep than usual. But the other restrictions that I mentioned are, I think, things that are similar to what we would see with ECT, like no driving on the day of the administration. You don't want to probably go back to work that day, make any important financial decisions, and just give people time to recover.
Thank you so much for the talk. I'm wondering if you could speak a little bit to dissemination of this treatment to out in the community. So it sounds like interventional psychiatry, UIHC, if someone is interested in learning more about ketamine treatment, that would be one place. Is this treatment widely available at community mental health centers and outpatient psychiatry clinics?
Yeah, so I think for IV ketamine, usually there's specialty clinics, and I know of 2 in the Iowa City area that are currently administering it. For like outpatient mental health clinics, I think one of the goals with esketamine was to have broader dissemination. If you don't need to have IV access, I mean, a lot of psychiatrists are not going to be particularly good at getting IV, and it's going to create kind of a different infrastructure where you might need a nurse in your office, for example, or a phlebotomist, somebody to come and help you with the necessary aspects of getting IV going. But I think hopefully intranasal has kind of obviated some of those concerns where it can be an office-based practice. You don't require any additional staff, I think, for the monitoring. So here we do offer both, but we predominantly offer intranasal esketamine, and I think it's been more driven by insurance and the patient's needs. If somebody wants IV ketamine in the community, they can get it elsewhere. So I think we're trying to be attuned to the patients that are most in need of a very effective treatment for a lot of people.
Wonderful. And if in order to be referred to interventional psychiatry, would someone ask their family doctor, their psychiatrist? What would be sort of the mechanism of getting into treatment?
So it's a good question. I should have mentioned that already. So for an interventional referral at the university, it would have to be initiated by a medical practitioner. It doesn't necessarily need to be a psychiatrist. I think we would prefer it to be your psychiatrist, but we've had referrals from family practice. Oftentimes we prefer the family practice person to first refer to a psychiatrist before coming to interventional. But if somebody feels particularly strongly that this patient would be a good candidate for TMS or ECT, is oftentimes what we see. That's another way, but you can't kind of refer yourself. Your provider needs to initiate that.
Great. Thank you so much. Any other questions? All right. Thank you so much, Dr. Niciu, for a wonderful talk and telling us all about all the evidence base for ketamine and esketamine and how to access this treatment in our community. Thank you so much.
Yeah, thank you.